I said I wasn't sure what to prepare for kind of transverse myelitis annual meeting, but I give a talk in our pain management program in the Wharton Center where I speak to patients on a regular basis. So I try to keep it in a kind of a patient-orientated way with some kind of scientific background. And I have to apologize, obviously, this is a transverse myelitis society, but the way how chronic pain specialists or doctors like me who have an interest in neuropathic pain classify the kind of pain we experience in patients with transverse myelitis. It's not disease-specific, for transverse myelitis. It's more a pain you get, from damage to the central nervous system. So my kind of the way how I go through the talk will be more a generic approach to patients with spinal cord injury pain, transverse myelitis pain, and not specific for transverse myelitis. And I have also to apologize that I cover fatigue, as part of the talk, but there used to be, I think, a talk separately for fatigue, and I concentrate a bit more in terms of trying to avoid and making fatigue worse as part of the treatment. I offer patients rather than focusing on the fatigue treatment because we know only a little bit about the pain in kind of these conditions, but we don't know hardly anything about the fatigue and what's causing it. So I think you can try to treat this symptomatically, but there is no kind of causative treatment for the condition. So this is our new Sid Watkins building where the neurology rehabilitation unit is now housed. And on the first floor we have a big pain management program where we see patients with all type of pain to teach them a pain management approach when most of the medical conditions have been exhausted. And that's where I do my clinic, and I think Caroline Young, the neuro rehabilitation unit is in this building as well. And this is Liverpool. I couldn't find a photo from a sailing boat to see it, so I had to download this from the internet, so I apologize for this as well. So, like I said, I want to give you a brief overview about central neuropathic pain, and I just explain why this is called central and not peripheral. I have some kind of prevalence and epidemiological data. Again, I couldn't find anything about transverse myelitis specifically, but obviously there are some numbers, how many patients suffer from central pain in other conditions. And I tried to explain how the pain world, or how people working in the specialty of pain try to understand why this pain comes about. And then I tell you how you have to do the diagnosis, because I think it's quite important nowadays to have a proper diagnosis. Otherwise, you are giving drugs which have lots of side effects to patients, and I think you need to have a good enough reason to do this actually. And then there are some guidelines now based on clinical trials and kind of meta-analysis, who give an evidence base for the treatment. And then I just go to the fatigue from how the nurses, do this in a way at the end of it. Like I said, this is just the content which reflects, what I want to teach you. And then I have a look at the end, what's on the horizon in terms of future outlook. And then there will be some time for questions, I think, at the end of the 3 sessions. So I'm a member of this Neuropathic Pain Special Interest Group, which is an organization worldwide who has actually been founded in the UK. But they have come up with a more tight definition in 2008, where you have to fulfill certain criteria until you have a diagnosis of definite neuropathic pain. And again, as part of this workup, they came up with some kind of more refined definitions. And we are quite keen now to actually identify a lesion, in the somatosensory nervous system, rather than just having a kind of a dysfunction or something wrong with it. So I think we try to really demonstrate that there is something damaged in the central nervous system. And again, this is a flow chart where you have pain as a kind of a principal. Pain as a principal starting point. Then obviously it needs to be distributed in where the nerves are normally innervating the skin. And if that's not the case, then it's unlikely that it's caused by the nervous system. And again, if this is the case, then you have at least a working hypothesis, and then you try to do some tests, like for transverse myelitis, I would, for example, do an MRI scan, and then see if there is something called a high signal in the spinal cord, where you can demonstrate the damage, from the infection, inflammation in the spinal cord, and that would then change, this probable, possible neuropathic pain into definite neuropathic pain. And you can now have a look, at more defined areas of the spinal cord where pain is transmitted. And again, we are working on some kind of imaging sequences in the Wharton Center that we can have a closer look at the spinothalamic tract, which is the pain tract in the spinal cord. And I would even be more pleased, if I could demonstrate there's some damage in this kind of pain transmitting pathways in the spinal cord, which then would explain, at least part of the neuropathic pain. So this is just the numbers, and it's actually quite a big problem. If you look at the worldwide population, 3.3% to 8.2% of the population have got neuropathic pain. And if you look at spinal cord injury patients, which are the best kind of studied patients, then 40% of them have got central neuropathic pain, secondary to the injury. And just from the mechanism, I would kind of guess that could be similar to transverse myelitis, because I don't think there's a big difference if the damage to the spinal cord is traumatic from a car crash or from an accident, or if you have an infection or kind of inflammation or an autoimmune disease basically damaging the spinal cord. Then I don't know if you know what a Syrinx is, but if you get some damage to the spinal cord, you get a filling of the internal canal with fluid. And that can be quite fluctuating because the brain fluid is generated on a frequent basis of 150 mils per day. And that can sometimes be the reasons that the situation changes and people have no pain for years, and suddenly they get pain, and you see a lot in spinal cord injury pain, but they are pain-free for 4 or 5 years, and something happens, and then suddenly they get pain. And most of the explanation for this is that they develop something called a Syrinx, which is this kind of fluid-filled caverns, in the spinal cord. And then, I see quite a lot of patients who have got central post-stroke pain, and I only mention this here because that's another one of the central pain syndromes, which we kind of take together in making a difference between peripheral pain and central pain. And then neuropathic pain in Italian MS patients has been reported of 28%. I see lots of MS patients, and I would guess the whole incidence of pain is much higher. But if you look probably purely at neuropathic pain, they are usually mixed pains. It's probably only 1/3. Again, in pain medicine we are very much kind of holistic, and we try to look at different aspects of the patient. And this just reflects, that even if you look, and patients come from a neuropathic pain clinic, you can't just ignore other pains. And I think most of the patients have a kind of a mixture of musculoskeletal pain because they're usually in a wheelchair, and the muscles don't work very well in the rest of the body. And if there's still some remaining sensation that can cause pain, then people get, painful spasticity, if they have got spastic problems as part of the central problems. And the headaches, from fatigue, and there's a kind of a big kind of collection of different pains which you can't ignore, and the treatment is a bit different, for musculoskeletal pain than it is for nerve pain. So I just put this up, to illustrate that we are not concentrating just on the neuropathic pain. This is just a questionnaire I use quite a lot because it has been validated in Germany, but it's in English, and it gives you an idea if the patients have mainly neuropathic pain by just looking at the answers patients give to these questionnaires and what they have on the kind of this body image, and the pain pattern here, how they describe it. And then if they score into this range here, by counting all the numbers together, again, that gives me a bit of more confidence that they have got neuropathic pain rather than musculoskeletal pain, because the treatment for the condition is differently. So I said I just take spinal cord injury as a kind of an example because, like I said, the knowledge is a bit better, and I used to work on a spinal cord injury unit in Australia where they did quite a lot of this work. And if you have probably I just try to translate this for transverse myelitis. So I think if you have a kind of myelitis starting at the level, then you can have at level pain. So if somebody has got a paralysis, from T1 downwards, if you then have pain around the T1 area, that's called at level pain, because that's more caused probably by the direct effect on the nerve roots innervating this part of the body. Whereas the below level pain is pain anywhere below this level of injury when you do a proper scoring. And the traumatic spinal cord injury guys, they use something called an ASIA score, which gives you a kind of a level where the different properties of the body systems are affected. And this below level pain is much more difficult to treat because it's something, it's a new onset. So if you get a Zürings, like in the slide before, and then you get suddenly a pain below the level of your injury, which is new, then that means that some of the pain tracts have been reconnected or something else has happened, and it's quite refractory or it's very difficult to treat. Whereas the at-level pain, you can treat as a kind of a normal peripheral pain, and it responds usually to things like pregabalin or certain pain drugs. And again, this, the mechanisms, what I just said with the kind of Zürings, which can happen at any time in the recovery of a transverse myelitis or of a traumatic spinal cord injury. And like I said, the idea is that some of the healing processes, they are basically generating the reconnection of fibers, which don't make you walk again, but they are basically reconnecting the pain transmission systems, and then suddenly you get a new onset of pain. And I think that's one of the expressions that even if something happens to your central nervous system, it's not static. There's a lot of dynamics going on, and there's a lot of neuroplasticity going on, which basically can explain some of the changes that happen later in time. But again, it's very difficult to prove all this kind of things because you need quite a large number of patients to have the same mechanism until you can come up with it. But it explains lots of the findings we have. So again, some of the patients here have probably been to spinal cord injury units, like the one I work with in Southport. They take patients who have got any type of spinal cord injury unit. It doesn't need to be traumatic, but I think that depends on the policy. So I work with Southport a lot. Again, they have a kind of a very good multidisciplinary approach. There are psychologists, physiotherapists, occupational therapists employed, and I think this is quite important. If you look at these patients. So the mainstay of my therapy is pharmacological, but I always, refer patients to other specialists if I think there are other issues. Pregabalin, is the one I just mentioned before, which is an anti-epileptic, which has got quite reasonable evidence in clinical trials for this at-level pain. It's still used in below-level pain, but the success rate is much lower than in at-level pain. And then I try, tricyclic antidepressants. They are just the old-fashioned ones like amitriptyline or triptyline, which quite a lot of pain specialists use. And again, they obviously have a sedative effect, and the same is valid for pregabalin at the higher dosages. So you need to be careful if people have a high dose of high level of fatigue. Then I want to make sure that first of all the diagnosis is right, that the drugs can work, and then I always do try one drug after the other, and only leave patients on medication when they get at least 20 to 30% pain reduction from it. Otherwise, you need to discuss, if it's worthwhile to stay on the medication if they make your fatigue and your sedation work worse. Then I try patients on strong morphine-based medication, but that can cause things like constipation. They can put people into retention so that they can't pass water anymore. Again, they contribute to fatigue a lot. So again, I do an individual trial in patients, and if they get a decent amount of pain relief, then I work out a kind of a long-term pain management plan with this type of drugs with them. And then there can be at some use, but I think it's not enough to just look at pain reduction. Patients need to improve in function, and I think then we have a better argument to leave them on this medication. Sorry, this is a kind of an abbreviation, but the Wharton Center is quite a large pain unit, so we offer most of the treatments available for pain treatment. And we do something called spinal cord stimulation when all the medication don't work, or as alternative to medication, you can actually try to manipulate the pain system with a neuromodulation device, which is like an internal TENS machine, and try to override the pain this way. Again, this is quite well established for at-level pain, but the below-level pain is not really responsive to this. So you can do a trial, but most of my trials I have done so far are negative. And again, we do something like an intrathecal drug delivery, in patients who are very spastic. You can't increase the kind of oral medication forever because there will get side effects, and you can try to deliver the drug much more closely to the spinal cord, and that's done with a kind of a catheter inside the spinal fluid. And again, that's what we do quite a bit. We have something like 80 or 90 patients who are on these drugs with a pump. It's a big commitment from our side, and they need to come back for refills on a regular basis. So again, it's something we offer patients. And again, TMS is called transcranial magnetic stimulation. I have a picture of it later on, which is a kind of a manipulation of the painful area, the part of the brain which actually senses the pain coming from the peripheral body, and try to manipulate the pain relief this way. And mental imagery is something that our occupational therapists and nurses used to still offer patients, where you try to kind of distract yourself, from the pain by imagining, kind of more pleasant sensation in this area from the past, and that can be quite effective in some patients, but it needs lots of training with the nurses, and our nurse who used to do this a lot, unfortunately has retired now. And we are planning to have a kind of a special pain management program, if all this kind of pain relieving methods fail, which is specific for kind of patients with a spinal cord problem, because most of them are wheelchair bound. Our pain management program can't take wheelchair kind of dependent people at the moment. And again, we had one of them in Australia where I worked, and that was very well received and quite successful. And I'm working to get one possibly established in the Walton Center in the future. So again, the kind of mechanism of the chronic pain in patients with MS, MMO, transverse myelitis, I think they are quite multi-causal, and except the musculoskeletal dysfunction will probably benefit from a good physiotherapy assessment and do some exercises. Then the neuropathic pain is probably caused by inflammatory processes in the spinal cord initially, and then things like reconnecting of these different pathways. And I think recent knowledge in pain has established that there are systems who are transmitting the pain from your skin and the nerve endings and the kind of joints into the brain, and there is another system which tries to suppress this kind of effect. And that's what I mean with the ascending and descending pathways. And the current explanation in patients with strokes and this kind of spinal cord injuries is that there is a disruption of this balance, so that basically the transmitting systems who go upwards, they are kind of overwhelmed, and then there's not enough suppression. That's the reason why the pain becomes a chronic, constant problem. And again, the lesions in the central nervous system, they can cause a kind of a reorganization of nerves, and then they work differently like the ones who have been there before. So when patients come to my clinic, I try to follow this algorithm I showed you before, and then look at does the pain correlate with the area where I can see the injury, on an MRI scan, or where patients tell me they had the injury. Then we do some kind of nasty tests, so with pinprick and cotton wool, and see if we can actually cause something called allodynia, which is it's a painful response to something which wouldn't normally hurt. So if you touch yourself with cotton wool over your forehead, it's normally not painful, but if you do this in an affected area where there's nerve damage, that can cause quite a lot of pain. And they are called positive signs. So your kind of somatosensory system who senses this stuff is just hypersensitive. And if it's not painful, just enhanced, then we call this hyperalgesia. But the signs are quite typical for neuropathic pain. They are not exclusive for neuropathic pain, but if patients have got the signs in the area where the lesion would normally be, that makes me much more confident that I'm dealing actually with neuropathic pain conditions. And negative signs are signs where you lose function. So if you're numb in this area, or the cotton wool is felt much less than on the other side, and the temperature kind of perception is abnormal, then again they are kind of helping with the diagnosis, and they are quite common, found in patients who have got this condition. And then the MRI scan in MS patients, we call them plaques. They are kind of demyelinations, in the spinal cord or in the brain. And obviously with infections like tonsillitis myelitis or inflammation from autoimmune diseases and injuries, I would like to see a high signal in the spinal cord, like I said before. Okay, like I said, I let you read through this quickly, but it's just the kind of summary of what I told you so far as we went along. Like I said, we can offer this multidisciplinary treatment in the neuro rehab unit in the Wharton Center and in our pain management program. Like I said, we have got a psychological service for MS patients, and the spinal cord injury in Salzburg, they have specialist psychologists for people with spinal cord injury, because I think it's quite important to have some help with accepting the kind of conditions, so that patients can then start getting better from the status quo, because if there's no chance of recovery, it's very difficult to go around in circles, rather than trying to take the status quo and then help patients to cope with what's going on at the time. And then that's what I mean about honesty as well. I go through certain drugs systematically in my clinic, but the kind of success rate of most of them is around 15 to 20%. So we will come to the end of all the drugs, and the good thing is that I don't leave them on drugs who are not helpful. But I tell everybody from the start that probably in a year's time you will be still in the same amount of pain like when you came. But at least then you have ticked all the boxes and you don't need to go around in circles. And again, the effects of drugs, they need to be balanced against how the quality of life of people improves. So if you put somebody on lots of morphine and they're only asleep all the time, I think that's not really an appropriate management. So that's what I try to establish, in discussions with the patients before we try the different medication. But there is a big debate going on in the UK at the moment about opioids and worldwide. And I'm quite engaged in this because I don't want to use this type of drugs for patients with severe neuropathic pain, because they can be quite effective as long as you know what you're doing and if you manage the patients properly. Again, spinal cord stimulation has not been used that much in patients with central pain conditions, but I think that's underused. So I'm trying to at least offer patients trials now and see if this would be an option in more patients, because again they can be quite effective, and you can then wean patients off most of the drugs, which then improves fatigue and other issues. I have this kind of balloon compression in here because we see lots of MS patients, and obviously they can have pain in the facial area as well, and we offer these treatments in the Wharton Center. And then, like I said, the pumps for baclofen, the pain management program, and like I said, we are doing quite a lot of outcome measurements and service evaluation to see if we can really improve our success rates, from different treatments we offer. So the fatigue is obviously a big problem for patients with central pain syndromes, or I think MS, and it's very common in fibromyalgia patients as well. So I see lots of patients who have these problems. I had a very interesting meeting yesterday with neurologists, and they are all kind of specialists in small fibers, which are the nerve endings, in your skin, who are transmitting pain signals, and they are looking at patients who are losing actually these fibers from conditions like diabetes. It seems to be in MS as well. And they have found that there is a big correlation between the small fiber loss and fatigue. So I hope that there will be some better understanding in the future what actually causes fatigue. But I personally consider it as part of the kind of symptom complex, that we have got these central pain problems from the underlying condition like multiple myelitis MS. And it's just part of the whole abnormality which goes on in the central nervous system and in the brain, which then causes a higher risk and higher frequency of fatigue in patients. So obviously the fatigue is interacting with kind of pain, and lots of people who have lots of pain or have a kind of a chronic condition, they get quite depressed, because they lose their kind of active life from before. I personally think this is in most of the cases in reactive depression, so you are responding to what happened to your life, and this is not very well responding to antidepressant drugs because they are usually treating organic depressions. So I'm not that surprised that patients come to me and they are on antidepressants for the kind of underlying condition, and then this antidepressants have side effects. So I always discuss the contribution of fatigue with some of the drugs they are on, because treatment for this type of depression is cognitive behavioral therapy and psychology rather than drugs, and obviously we can offer this to patients, and that can sometimes help. So again, what we do on a pain management program as well is we try to teach people kind of self-management skills. And the first step is obviously that you need to understand what makes things worse and what makes it better. And then people fall into kind of behavioral traps, that's a problem in pain, because pain is a very strong stimulus to try to avoid, and then you become less and less active because you try to avoid pain, and you're in a kind of vicious cycle. And that's one of the things which are probably true in fatigue as well, that you learn that you will be very exhausted by doing too much one day. So the kind of treatment plans, in a cognitive behavioral therapy program is to make people understand and then teach them how to do a stepwise approach so that you don't put too much high targets on and you fail them, and then do kind of regular exercises, and hopefully you can build up your stamina in a certain way by following this kind of algorithm. And the kind of idea from this picture is basically to try to break this cycle, and then hopefully you will get an improvement afterwards. Again, there are the different fatigue types, and what like I said with this discussion we had yesterday, I don't think we exactly know what's causing the fatigue, but I'm sure that if you damage the central nervous system in a profound way, like what happens in transient myelitis, NMO, and MS, that this will be some of the explanation for the fatigue as well as the pain. And then because you can't move neurologically from the kind of disconnection from the nervous system, some of your muscles. And I think that changes the whole energy balance in your body, and that could explain that you are much easier exhausted. And obviously the secondary factors are that people have got all these other problems like pain, like sleep disturbance, bladder symptoms which make you get up at night all the time, and then you have never a proper night's sleep. And I think they are contributing to the whole difficulty with it. And that's the same thing with this kind of chronic pain management, that I think it needs to be defined what's is the target, or what you want to define as normal, taking all the factors into consideration, and that what we call realistic goals, that you will not never return to what you remember yourself at the age of 18 or something. I think it needs to be a realistic goal, what you can achieve, and then try to target the kind of learned adjustments, towards this kind of goal you have defined. There seemed to be an emphasis in our MS nurses, that you can help fatigue patients quite a bit with keeping well hydrated, and I'm sure that's right. That I feel this myself. I don't drink regularly, that I become quite fatigued. But there seems to be some evidence in the nurses kind of literature, and this kind of common sense and normal life advice, is from the slide, from the nurses. And I think it's important to look at things like chronic disease anemia. If your hemoglobin is only 8, then I'm not surprised that you are quite tired, and obviously that would indicate that you need iron tablets or even a blood transfusion eventually. The patients are not seen in isolation, so you have always to really consider if there are new infections taking place, if there's something else happens to the patient, and then we explore, can you treat this medically and with some other therapy to improve the fatigue symptoms. Again, I mentioned this already going to the other slides, but there are such specific drugs who can make the fatigue much worse. And like I said, I mentioned opioids here. There are better ones available now. There's a new drug called tapentadol, which has much less sedative side effects than morphine. And other antispastic drugs, I'm not sure if any of you saw these drugs, but they are sleeping tablets as well, and they work on the same system like you normally give patients medication to go to sleep, and it's no wonder that patients are very tired, particularly if they take them in the daytime. This gabapentin, pregabalin, particularly if you go to the higher dosages, and what I said before, that is a damage to the central nervous system, so you need to get these drugs into the central nervous system to have an effect. So you need to go higher on the dosages, and then they get all the side effects, like they make you very tired. And other tablets, that's clonidine and beta blockers, which are used as antihypertensives, that can contribute to fatigue. And then antidepressants, particularly from these classes, and antihistamines, some people take for itch, or some people take for side effects from opioids. And like I said, if fatigue is a big problem, I changed my kind of risk-benefit discussion with patients quite a bit and try to wean people off drugs and see if they improve, or the fatigue improves and the whole quality of life improves. So again, this is kind of this balancing system that you try to generate the best levels of energy by looking at the side effects of drugs and give good nutrition, try to cure things like deficiencies of iron or vitamins, and then you need to learn to manage this kind of energy you get from this optimized treatment, so that you make the most out of it and get an improvement in function and quality of life. So again, this is a kind of a pain management approach that you need to have a plan, what you want to do at one day, and then we call this pacing in pain, but you try to do smaller steps, but more frequency, and give you regular kind of breaks, and then hopefully by applying this kind of common sense principles, that will help you to achieve what you set out to do on this day. And again, there are kind of effectiveness strategies our nurses teach people with fatigue. Like I said, we offer on our pain management program mindfulness, but some of the pain management programs use this relaxation kind of techniques, deep breathing and yoga, and obviously they're all kind of contributing to strengthening kind of muscles, and try to use them in a more efficient way. So the summary of the talk is that up to 40% of MS patients, I would say patients with central damage to the spinal cord, can get this neuropathic pain, and it is a big problem in this population. Like I said, I see 4 new patients or so with this problem a week. And the treatment can be effective, but it needs to be balanced against other factors, and it is more not effective than it's actually effective. And the kind of research we are doing in Wharton Center, and I'm interested in, is to understand the kind of underlying mechanism of this pain problem much better, and then hopefully we have a kind of a way how we can see from the from the start that these patients will have these symptoms and they will respond to this type of drugs rather than going as a trial and error through all the drugs systematically, which is quite time consuming and can actually expose patients to side effects which are not even necessary. And like I said, we do this kind of treatment in the Walton Center where we upload MRI scans, on a brain navigation system, and it's a kind of a coil which treats actually the surface of the brain with electromagnetic waves. So it's not invasive, so you don't need to put any holes in the head or something like our neurosurgeons do. And then you can target, certain areas, like if this patient has got pain in the right arm here, then you would find the kind of representing area on the motor cortex in the brain, and then you can navigate this kind of coil here over these areas and try to stimulate the brain to form new connections, and these new connections then can actually override pain signals. And that is effective in probably 30 to 40% of the patients we have seen so far. Because if the damage is on the spinal cord level, and then it's no point to manipulate all the kind of pain signals coming from the skin because the damage and the malfunction is in the spinal cord. So the only chance you probably realistically have to improve this is to go one step higher in the chain of command in the nervous system and try to achieve this there. So I leave it at this point, and thank you very much for your attention.